And you can see the screen?
Also, yes.
Okay, well, good afternoon, everyone. So I'm the Director of Lysosomal Storage at NYU. Know most of your families here, and I'm a pediatric neurologist by training. So today I'll be talking about the Canavan Natural History Study. Here are my disclosures. I work with pharma in a lot of rare disease drug development projects, including now gene therapy. So I want to first start off by talking about, the natural history study in general. What are the goals of a natural history? What are we doing? I know that we've talked about it over the years, but it's nice to just revisit this. And in general, the goal of a natural history study is to define the range of the disease manifestations. What are the common manifestations among patients, and what are the rare manifestations or unique symptoms that distinguish patients from each other? Are there any genotype-phenotype correlations? Different mutations confer a more severe course, or do they confer a slower course? And then the next goal really is not just to take a point in time and interview everyone and to understand that patient at that point in time, but it's really to see how these manifestations, the disease progresses and changes over time. And so especially with Canavan disease, we want to understand the ages of onset. Is it in the birth perinatal onset form? Is it the neonatal within the first few months of life? Is it in infancy within the first 3 to 6 months of life? Or it's later in the first year of life, or even in childhood? And then as we categorize each type of group of patients in that subset of that disease, here in Canavan, we do see a conatal form, we do see an infantile form. And then to look at those, how the child changes in development over time. In this case, global development, language, cognition, gross motor, fine motor. And so the first, what we look back in time is to try to understand what are the first signs and symptoms of the disease that may or may not have been noticed by a clinician, but actually maybe noticed by a family member, the mother. And so it's important to understand not only the current symptomatology, but what does the parent recall from the beginning, and to document that across different patient groups. And then we want to understand the trajectory of the disease. Are we first developing and gaining milestones, and then is it followed by a regression? Or is it a slow development, slower than the average infant, and then followed by a regression? In certain diseases, there's actually a period of stagnation or plateau, and we see that in some of other neurodegenerative diseases, where there might be initial developmental delay, and then a stagnation, and then a regression or decline. And from watching the children over time to understand how fast or how slow. What's important to know is that every child develops differently in general, but can we see trends? Can we see an overall trend of how fast or how slow each subtype of the disease progresses over time? Is it in weeks? Is it months? Is it years? And the best reporters of that are the parents and the family members of these children. And then another goal of a natural history study is to look for silent or subtle markers of the disease, and that change early and quickly. Is there some kind of a biomarker in the blood? Is there a marker in the radiographic or the imaging of the brain that we can see early changes if we were to catch that disease at birth and follow forward? And how does that change? And would that be a better marker of disease course in the early period? And are these markers or manifestations, which ones are reversible? Which ones can be altered and either stabilized or even reversed? And this information is what we're trying to glean from a natural history study that takes place not only for just one visit, but multiple visits over months to years if possible. So once we define the disease and we determine which aspects of that disease that we know a lot about, we try to find a way to measure it in a systematic and consistent way within that same patient and among patients. And this is to help us develop clinical endpoints in a trial. Our goal really for a natural history study is to inform how to design an interventional trial. Once we have a therapy ready to study, to see if it's efficacious, we have to understand how to measure efficacy in a short time period. Sometimes a medication can be started and we won't see a major change over maybe a year or two, but we want to look for subtle changes or early markers of the disease and see if if an intervention has a positive effect on the course of the disease. And the endpoints are variable. They could be obviously physical exam findings, gross motor capabilities, fine motor, simply tone, especially in Canavan disease. Truncal and head tone is an important manifestation of the disease that if we corrected, maybe that would help us understand how maybe it would herald that we could start to develop forward. So cognition and language is an obvious one. Vision, whether we can stabilize it or prevent the visual decline we see in Canavan. In certain respects, behavior of the temperament of the child, irritability could be another endpoint, maybe not a primary endpoint, but again, we want to look at the child holistically. Prevention of certain manifestations such as seizures and see if we can alter that course. Functional aspects, including feeding and sleeping. Those are other aspects that, again, are very important in the life of a child. We can also look at quality of life aspects for the child and the family. And again, I mentioned radiologic and also blood and urine markers. So let me just go over into the actual study that has been supported by ASPA Therapeutics. And so I've been working with ASPA for a few years now, and it started in my little pilot study that I had a pilot grant from NTSAD to start looking and categorizing Canavan disease. And from there, with the help of Dr. Eichler and Dr. Bly, so Florian Eichler in Mass General and Dr. Annette Bly in Germany, Hamburg, we got together to help create the Canavan disease natural history study. ASPA is fully funded, retrospective and prospective. So what's really rich about this trial is that they're trying to not only capture the historical data of children at different ages, but also to follow them forward. And so this was started officially in November 2019. And as of May 26th, we have 19 patients referred to various sites, 17 of which were consented. And at the time, we cohorted the patients by age. Cohort 1 was less than 18 months. We have 3 patients. We have 4 patients in cohort 2, 2 patients in cohort 3, and 6 patients in cohort 4. And so what's important about this is that we really do want to understand the disease at different stages, cross-sectionally, so right now, and then as best as we can to capture the historical medical history of each of these patients from neonatal period and onward. And so not only did they support meaning that there was the trial is completely supported financially, they also provided a service to patients to help and their families to capture medical record retrieval. And that was really critical because it's very difficult. That was one of the barriers in my little study, was to work with families on one-on-one to try and grab the information from different hospitals and clinics, and then to put it all together and extract the developmental information. And so this is huge, a barrier to overcome that was provided by ASPA Therapeutics. And that's ongoing, and it's actually very rich in information that will help us inform the interventional trial. But in addition to that, there were prospective assessments. So there were going to be on-site visits as well as in-home assessments. However, as of March, due to the COVID pandemic, we had to pause due to safety, and we started to alter the approach. So just to review, for the original assessments, looking at some key features of Canavan disease, which is the gross motor delay, language and vision, we started with a bunch of different assessments that have already been validated. So what does that mean? Validation means that it's been tried out in other disease states and found to be consistent and reliable. So if multiple people would perform it, we would hopefully get the same result on the same patient. And then over time, it would help to monitor the individual patient over time consistently. So with remote consent ability, which again, we were thinking about the patient and their family, how to reduce the burden of being in a non-interventional trial where the benefit is not direct, right? You are providing information to us without a direct benefit in the moment to your child. And so remote consenting was an option. And one of those options within that was just simply to provide your medical history without having to undergo site visits or just have the in-home assessment. So at the site visits, the frequency varied by age, more frequent in the early stages because that's when there's rapid development of the child, and then longer between visits, longer time periods between visits as you age because things don't change as rapidly. The data extraction was then given to us once consent was signed. And then in-home assessments. This was amazing that fully supported physical therapists that were trained would go into the home and perform these developmental assessments. And that provided consistency because it was the same trainer and relieved the burden to the family from traveling to site frequently, but also being able to observe the child in a comfortable setting to maybe get their best effort in the different assessments. And so overall, this trial really aimed to gather the information while trying to relieve the burden of the visits and of how much the family had to contribute of time and effort. So looking at the pre-COVID remote assessments, we looked at different developmental motor scales that are listed on this table here. The disease severity scale that was generated looking at my clinical knowledge. Aneta is, Dr. Bly has been caring for Canavan patients for a long time and has systematically developed a questionnaire and has been looking at that. And Dr. Eichler, the three of us with ASPA's help, created a rating scale that we'll hopefully be piloting that we are piloting to help see if it helps to have a specific scale of severity. And we also looked at the impact on family, adaptive behavior scales, the extended interview, the quality of life, and the Canavan questionnaire. Of course, then we had our medical aspects, including physical exams, neurologic examinations, eye exams, and lab tests. So this is just a slide to show you that each of these scales looked at various aspects of development, including gross motor function, fine motor. The Bailey is very interesting because it can measure in infants cognition, language, social, emotional development, as well as adaptive behavior as young as 1 month. So we already have these scales in use, and we're trying to see if these scales are sensitive to picking up the change in a child with Canavan over time. And that's what we're trying to understand. Which of these scales will tell us the progression rate and the degree of severity, and have that fine assessment so that maybe this is what we could use in an interventional trial. So we're piloting it here when we're not having any intervention, just to understand the natural course of the disease. And again, this is a little bit more of the definition of the Vineland and the PEDS-QL. So again, assessing a slightly older, 5 months to 16 years of age. Okay? But then COVID-19 pandemic happened. And I'm sure that most of you have been impacted in various ways. And when I looked at my rare disease community, my population that I care for, we immediately wanted to ensure that our patients were safe. We do not know what the effect of COVID-19 has on our rare disease patients. And so in my institution, in my program, I erred on the side of, just assessing that it's a higher risk for various reasons, and to take precautions. So that was on a clinical aspect, but in the aspect with regards to clinical research, that's a whole other risk assessment. So as a patient, in New York, right away we decided to shelter in place. We reduced their movement around the community. We prevented people from coming into the home. These were all guidelines for our rare disease patients. Mask and precautions and hand washing, hygiene, and trying to reduce the number of exposures to the outside world. Now that's for day to day, but when we're doing a trial, it was very difficult to to go forward with certain trials. And in NYU, we had to actually look at each type of trial to assess risk versus benefit. So if you can imagine, the exposure to COVID accidentally either en route to the institution or within the institution or just being out and about was significant at the height of the pandemic. And so we had to weigh that against the potential benefit or lack of benefit from participating in a clinical trial, which is a voluntary, So the couple of questions that I had for, and most of us as principal investigators had to address were, is the disease state life-threatening and rapidly progressive? And so, yes, so Canavan is, and some of the other neurodegenerative diseases that I care for are. And so that we could take that risk. Is this trial looking at, is there already some disease-modifying therapy that the child could have access to outside of a trial? In this case, no. But is this trial interventional or non-interventional? So in this case, this is where we had to halt it. It's a non-interventional trial with no direct benefit. So we did not want to risk our patients and subjects to come to site or even have in-home assessments with physical therapists, even if we took precautions, not during the height of the pandemic. And so that's where we had to pause all of our natural history studies, actually. And then if there was an interventional trial in general, we had to weigh again, is it life-threatening? Is there any other therapy available? Or should we go forward with that? And so here, in medicine, there's our tenet is to first do no harm, and we have to protect our human subjects. So it was very frustrating because we just started off on such a great footing with the natural history study and started with the in-home assessments and everything. And but then we had to pause. Now the infection rates are dropping, but we still need to be very careful. And so we're looking at how to adapt each of our trials to minimize risk to the families. And ASPA's doing the same thing. So what they been working with us, myself, Dr. Eichler, and Dr. Bly, and many others in the company, is to how to reduce risk of exposure and utilizing remote assessments and try to minimize any kind of in-home interaction. So we halted some of the assessments, the GMFM, the Bailey-4, which require the physical therapist role. And we did more observational, we're considering more observational assessments, the Hammersmith, even the developmental milestone, the Canavan disease rating scale, the questionnaire, and the QOL. So we wanted to be able to perform that through a telemed or a video visit and record it, and then try to cover the domains and scale them or rate them remotely. So we're looking at the Alberta Infant Motor Scale, can be done remotely, the Hammersmith, looking at the developmental milestones, and even using just a simple milestone checklist to still see if we can capture prospectively going forward in real time the patients that enrolled to see if we can continue to define the disease course. So, as we're doing that, what are we going to do with this? So I've already alluded to it. We've already talked about it. So the results of this natural history study will inform the design of the interventional trial. And it's not just this interventional trial. This information should be generalizable to lots of different potential interventions. And so we hope to gain from the natural history study to define a set of assessments that are most sensitive to change in our Canavan patients, and that assess and allow us to understand how the disease impacts function. And it has to be clinically relevant. It cannot be just a simple biomarker of the disease, but how does it alter the function of the child? That's significant, that's relevant. There are age-dependent assessments. Children of different ages, how do we assess them over time if they're entering the trial at a different age, say from 3 months versus 6 months? What assessments are appropriate at each stage? And then we have to define the period of intervention that would be most able to be amenable to change from an intervention by a drug. And hopefully, these assessments would then be used to determine whether the drug has an effect. And that effect may not be, you know, as robust as, say, reversal of symptoms, but it could be as simple as stabilizing the disease course. If we understand there's rapid degeneration in this 3 to 6 month period, and actually we start to stabilize that disease, we could say that that might be a positive endpoint. Or we're improving the disease course is an obvious one, or slowing it. Obviously, if we showed remyelination, that would be very impactful, or developmental gains, that would be huge. But we also have to look at different ages, simply stabilizing might be a target, a goal. So this is particularly important when the disease is very rare and life-threatening. We need natural history data so that we understand each disease state and know what to look for so we're not missing it. Had we not done some research, we would have still thought that there was optic atrophy that was predominant in Canavan disease. But Dr. Bly has been seeing other forms of visual impairment that should be measured differently, possibly. So these are all very important to study in that natural state. And this, at times, could potentially replace the need for a placebo arm of a trial. When we have a rare disease, or when we have an intervention, we typically, the gold standard trial is to compare it against a sugar pill, an inactive intervention versus the active drug. And that's blinded to the family, the patient, myself, and the institution, looking to see does one stabilize or improve and the other one declines. And that's very tough when we're dealing with a neonatal onset or infantile onset disease that's life-threatening. So if we could show very clearly the disease course, the general disease course for most patients, that could maybe be accepted by the authorities as a, you know, in place of requiring a placebo arm. And oftentimes I do see, you know, in these life-threatening conditions that we don't need the placebo arm, but we still need to understand what is working. Is the drug working? To put a child under a risky procedure or intervention, we really need to understand the safety profile of that potential of that intervention, but also how do we measure? How do we know it's working? How do we know it's actually working and not just this child is acting a little differently than another child? And that's what the point of a natural history study is. And that's what we've been doing so far. So I'm going to pause here for questions. And I'd like to thank all of our patients and their families who've contributed their time and efforts to the natural history study. And obviously to my team who has helped us through all along, and especially in the last 2 months during this pandemic. So I'll pause here. Thank you.
Thanks, Heather. There's one question that's come in through our question and answer to the Q&A box, which was a question asking if the current cohort count of 19 is enough to gather the necessary natural history data, or do you need additional patients?
Obviously, the more, the better, right? We're hoping, you know, so I'm bringing this slide up because 19 sounds like a really robust number, and it is quite good for a rare disease. But what we need, actually, and it's limited because this is a rare disease and it's not necessarily being diagnosed very frequently. We do need some more numbers in cohort 1 and 2 to understand. So as much as we'd like to, as much as we are thankful for the historical data from consult notes and the medical record retrieval, it's still limited. If we follow someone forward, we know the questions we want to ask. And so that's why a prospective aspect of this, this study is so important to see in trained eyes between us, the neurologists, the physical therapists, to see how the child's changing over time, to see if we can pick up something. So we would obviously love more, and we are enrolling. There are options for remote, completely remote. I mean, we're doing that now anyway, but even before, to donate the original medical records for extraction. So I think, you know, it's important if there are children in cohort 1 that would meet cohort 1 and 2, that would be more robust, and we would probably need more data from that aspect, yes.
Thanks. Are you, on that note, would you also be open to enrolling additional patients from cohorts 3 and 4? Are you specifically looking for the younger children so that you'll have more prospective data rather than retrospective?
Now we have 3 sites, 2 sites in the U.S. We are raring to go, so we will take as much data as we can. The fact, that we have the support of ASPA Therapeutics and their data extraction service, it's just taken a whole load off of us independent investigators. It's really hard to do this as a solo or even with, just as an academic physician. So there are so many, they've been so helpful and they're so supportive that any data, anything you can do in cohort 3 and 4, yes. But there's sometimes a hesitation if it's newly diagnosed. It's very difficult for a family to, the idea is that you're caring for your child. You have to think about their daily needs. The last thing you want to do is to have to worry about, trial assessments. You're just trying to figure out how to care for your child and deal with that news or their ongoing issues. So we're trying to do this as, supportive as possible with the least amount of interruption in your life. And hopefully, you can't get direct benefit, but just from the knowledge and from us talking with us. So again, if we would accept any patient in each of the cohorts, there is utility in older patients, especially their initial medical record.
Great. And along those lines, is there an upper, maybe you mentioned this, is there an upper age limit to cohort 4? So obviously you spoke mostly about children and development, and but we know that our Canavan community includes young adults, and obviously greater than 5 years of age is a big age range. So is there an upper age limit?
No, there isn't actually. And that's because, we're, at that point, we'll take any data we can, and it's more of the visit. So the visit frequency greater than age 5 is for anyone, it's less rigorous, so we don't have to see very often. And so there is no upper limit, actually. We need to understand. I think when we started years ago, with companies, they don't know what the disease looks like at different stages, and that's really informative, important for those who are developing drugs to understand what does the disease, manifest at each cohort. So I remember trying to describe my patients who were 18 and 20 actually, and understand what their exam and everything. So absolutely, there's no upper age limit.
Great, and then I have one more question, but if anyone else has questions, again, feel free to type them in the Q&A box. So you talked about how you've changed your design due to limitations of the COVID pandemic, and certainly this has been a challenge for, I think, families and for healthcare providers around the world at this point. Are you going to be able to incorporate the data that you've already collected from the assessments that you're no longer doing because you need an in-person exam for those, and how are you going to be able to use your pre-COVID data alongside your post-COVID protocol data?
Yeah, I think it's the way you look at it, and again, this will be in concert with the company who is, I think, online as well, but the way I look at it is that the scales that we had to remove, which are so nitty-gritty and granular, and then the ones that we're doing are more a gestalt or more observational. So it's definitely data not lost. So any data that we have on the GMFM, it's not lost. It can be reinstituted once it's safer to have in-home assessments if they're, in the near future. It'll be difficult, but again, this is why this is a natural history. We're exploring what are sensitive changes. So if the Hammersmith ends up being adequate, actually, that's very generalizable. It's looking at, and I know what I'm looking for because I've cared for Canavan patients, so does Dr. Eichler and Dr. Bly. And so we work with the company to understand more, is this a validated way? And we'll go from there. It's difficult, but I think we're not the only disease state that is dealing with this. So we will incorporate our knowledge from those other assessments. But, there is a limitation. We can't just collapse the data.
Great. Well, thanks, Dr. Lau. And with that, I will ask Jenny LaForette to bring up her slides and to give our last presentation.